Hey,
Really.
Stephen, how are you?
Hey, Brian, I'm good.
Nora.
Hey.
All right. Why don't we go ahead and get started? It's 2 o'clock. Let me see who we have. Um, Justice Boggs indicated that he would try to connect if he could, but he has a number of things going on at present, given that he's ascending to the Chief Justice role. And we wish him well. He's going to do fantastic things for the state and for the judiciary. So if he can't attend, we understand. We've got Sarah Harris, who's been a champion for reform in this space for quite some time now. Sarah, good to see you. Karen, we also see that you are here. Dr. Bailey, thank you for being with us on a Friday afternoon. I know that there are a lot of other places that everybody would prefer to be. We also have Nora. I see Nora. Hello, Nora. Broadcasting live from the downstairs of your house. Do we have Representative Hogan with us today?
Representative Hogan has COVID for the third time, and he's really sick. So y'all pray for him.
No, I will, absolutely. Having been stricken with it myself once, I know how tough that is. All right, so he's not with us. Judge Hargrove has previously indicated that she would be unable to attend. Judge Kelly, it's good to see you, my friend. And I also point out that Vic Reynolds, who was a member of the committee, has recently been appointed by Governor Kemp to the Cobb County Superior Court bench. And so I've been told by our chair that the next GBI director will be a part of our committee, but Vic is now making that transition. And so we are unable, unfortunately, to have his participation. I also see that we have Dr. White with us. Dr. White, thank you for being with us. I would greatly appreciate you taking the time to be here. All right. So we have a quorum. I'll declare that a quorum exists. I've already spoken about Vic. Everybody should have received an email with the documents from all of our presenters. If you haven't received such an email, please let Lynn Chambers, my secretary, know. We are very excited today to have three presenters with us. We have Carol Bella, and if I've mispronounced your last name, Carol, I apologize. Carol is relatively new to the department, but she has rolled up her sleeves and done an excellent job of getting involved in this AOT implementation right away. And she will be first on our agenda to talk about that AOT implementation. The second person who'll speak to us is Monica Johnson, who's going to be joining us afterward, after Carol's presentation, to talk about really adult mental health services offered by the department as we begin as a committee to look upstream at ways to reduce arrest, hospitalization, and incarceration, and to see how those interventions that Monica describes help us with that. Next, we'll hear from Stephanie Lopez Howard, who's recently come out with an excellent academic article that's focused on the prevalence of the mentally ill in local jails. And we look forward to her sharing with us our findings. And I think that once we hear them, we hear the rigor around her work, we will have some concrete information, concrete data to show the fact that our local jails really do have a problem with an overabundance of people with severe and persistent mental illness. And that will again stress the importance of us looking upstream in addition to AOT to try to find ways to prevent this flow of people from the community and the public health side into the local jails. Again, with the idea of looking at those interventions as touch points where potentially we could make a difference in helping to reduce arrest, incarceration, and hospitalization. So that's sort of a very broad overview of the meeting today. And we look forward to some discussion at the end with Stephanie. And so again, thank you all for being here. Let me turn it over to Carol at this time. Carol, whenever you're ready.
Yeah, thank you, Judge. It's a pleasure to finally see you kind of face to face and virtually. So thank you for having me. Michael, if you are able to pull up our presentation, thank you. So hopefully everybody can see the screen. We can go up one, Michael, to the beginning. Thank you. So I just wanted to take a little time and kind of introduce myself. As the judge mentioned, I am new to my role. I'm also new to Georgia. I'm originally from Miami, Florida, having moved here in December of last year. So in Miami, my role was as Vice President of Behavioral Health Services at a private nonprofit organization that oversaw the safety net services within Miami-Dade and Monroe counties. In that role, I was responsible for oversight and monitoring of adult and children mental health and substance use services. So this included anything from an outpatient setting to inpatient services, such as the CSU, residential treatment. I also oversaw peer support, child welfare integration, housing integration, care coordination, forensic services, and our local police and mental health initiatives, which included developing the first corresponder team and case consultation with Miami-Dade Police Department and partnering with other law enforcement agencies. Prior to this, I worked as a director of the programs at a state hospital, and before that at a community psychosocial rehab program. I am CIT trained, a CIT coordinator, and also a SOAR trainer. So next slide, Michael. Thank you. So this is the agenda that we will be discussing today. So first, what is AOT? Gonna talk a little bit about our pilot site, our advisory committee, and some of the legislative requirements from the House bill, some of our challenges and opportunities, and then we're gonna open it up for discussion. So what is AOT? AOT is a community-based mental health treatment that is provided under a civil court commitment. The goal is to engage individuals that have difficulty following their treatment plan and providing them with additional support to be stable in the community, reduce the number of inpatient admissions to crisis services or encounters with the criminal justice system. The focus is on the treatment provider to keep the individual engaged in those services. Next slide. So AOT's targets population are adults with SPMI or co-occurring disorders that appear to be stuck in a revolving door of frequent inpatient admissions and or arrest, and they've demonstrated an inability to really successfully engage or participate in their treatment voluntarily, and who are at a risk of harmful behaviors to themselves or to others. Adults that are in AOT will be supported by a team to help them navigate the court process that may potentially have proven difficult without that assistance, and will receive linkage and follow-up to needed community-based services. I wanted to point out that the AOT shouldn't be the first course of treatment, but really used in limited circumstances where all other means at engaging an individual have been exhausted and less restrictive settings have failed. Next slide. Thanks. In an effort to continue to expand adult mental health services and provide supports to these individuals that are experiencing difficulties and challenges with maintaining their treatment, the department funded an AOT enhancement pilot through ARPA funds for the individuals that met the AOT criteria that I described previously. The focus of the pilot is centered around communication between the treatment provider and the court. As mentioned, the treatment provider is tasked with keeping that person really engaged with their services and following their treatment plan. So the relationship between the provider and the court is extremely important and really a primary focus. The ARPA funds are approximately 1.4 million, and they're slated to fund 2 AOT sites with 3 staff each, the clinician, a peer mentor, and a case managers. And again, the goal of this pilot and of AOT is to reduce the need for high-end services like hospital admissions, reduce the number of crisis responses because individuals will be linked to services and have the support of a team, and then reduce the interactions with law enforcement. The AOT pilot staff, so the clinician, the case manager, and the peer, again, are there to provide support, engagement, linkages to service, that follow-up, encouragement, so that the individual increases compliance with the recommended care. The staff is there to be a liaison between the individual, the provider agency, the treatment team, and with the court. So the current AOT pilot site was selected based on their working relationship between the provider and the county's probate court. It's important that the pilot sites have some working knowledge and really some understanding of the involuntary commitment process in Georgia and the willingness to do this work. So New Horizons and Muskogee County Probate Court Judge D'Antonio was selected as the first site, and they became operational in January of this year. Here you're going to see some of the outcomes that we intend to see with the AOT pilot. So on the left-hand column, you're going to see outcomes for the participants. So we expect increased engagement with their treatment provider as they now have a team that's going to support them in their walk towards recovery. The participants should experience more meaningful life experiences as they'll have less admissions into patient settings or jail, and hopefully more connectedness to their community. With medication and treatment compliance, a decrease in harmful behaviors towards themselves or others. Want to see a reduction in arrests and hospitalizations, reductions in being the victim of a crime or the perpetrator of a crime, and an increase in housing and community stability. For the communities, a reduction in cost of hospitalizations and incarcerations, which is going to show a cost savings to the community, a reduction in the use of law enforcement for crisis services, thereby allowing law enforcement to focus on public safety, a reduction in the use of inpatient beds, and a reduction of the mental health population in the county jails, which is a focus here. As part of our AOT rollout, we really wanted to focus on data collection. So here you're going to see some of the quantitative and qualitative data points that we're going to be collecting. So on the quantitative side, we want to look at the number of crisis contacts, and that will include emergency receiving facilities, mobile crisis, EMS, and law enforcement. The number of contacts with the judge, whether that's an informal or a formal contact, number of arrests, number of days spent in jail, the contacts with their support team, their AOT team, admissions and numbers of days admitted into an inpatient facility, and any changes in their housing stability. So the quantitative information is collected through various reports, such as monthly clinical updates. We have an AOT individual report and a monthly programmatic report as well that provides us information on census, the number enrolled, if anybody's been returned to voluntary, if anybody's left program, any crisis contacts, et cetera. Attempts are going to be made. Attempts are going to be made at collecting these data points 1 year prior to enrollment and 1 year after the order is lifted. So on the qualitative side, we're going to be looking at their interactions during the court proceedings and during treatment team meetings, the quality of the information about the program that's actually provided to the individual's level of confidence that their privacy has been protected, the benefits of the program, and suggestions for improvement. So we're going to be using satisfaction surveys post-enrollment, and these surveys are going to ask about participant experience while engaged in AOT, their satisfaction with AOT, with the court staff, with their treatment team, their participation in treatment, reasons for not wanting treatment. These kind of items are going to be in that survey. Data collection is actually a really high topic of interest at our AOT advisory committee meetings, and it's going to assist with tracking success and really identifying opportunities for the programs. Next slide. Thanks. So New Horizons and Judge D'Antonio have been active for approximately 6 months with 3 participants. We've recently identified a second site with Judge Chastain in Gilmer County and with Highland Rivers. Judge Chastain has begun participating in our meetings and has also started attending virtual AOT hearings with Judge D'Antonio. So at this point, I'm going to take a break and we're going to show you a video with Judge D'Antonio and Dr. Patillo.
We're not able to hear him, Carol.
See, Michael's figuring it out.
Give us Just give us a second so we can get the sound worked out.
Okay.
Thank you, Judge Amira.
Thank you.
1 second, guys. Sorry about that.
My view towards dealing with both guardianships or involuntary treatment cases really comes down to trying to put myself in the shoes of the individual that I might be ordering into treatment or interfering with their rights. Well, Columbus has been doing outpatient treatment generally for a longer time than probably any other area in the state.
We have a very good relationship with our probate judge, Judge D'Antonio. The attorneys that we work with are really experienced and knowledgeable about mental health and have been doing this, all of them have been doing this now for several years.
I am a big advocate of helping people maintain independence in the community. And I strongly believe sometimes assisted outpatient treatment is a way to prevent people from living in more restrictive environments, whether they be hospitals or quite frankly, jails or prison. My predecessor started in 1998, and that was the year that we first started doing involuntary treatment on an outpatient level. An individual does have to have some insight into their mental illness in order, that's probably what drives an individual being placed into involuntary treatment, is their lack of insight into their illness.
I look for somebody that if we can get their medicine in them, will they do better? Yeah. And are they at a point where they're either going in and out of the hospital or they're going in and out of jail, or something about their mental illness is really significantly impacting the quality of their life and putting them at risk?
Well, I'm encouraging probate judges to jump into this and learn from me, learn from some of the others. You do have to have an understanding of psychiatric disorders. You have to have an understanding of medical terminology, medications. In terms of getting other judges involved in it, that they be willing to listen to others, to defer to clinicians and experts in the area, but also to be comfortable questioning things. If I don't understand somebody, what a clinician is saying, I'm going to ask them more questions about it.
My experience of doing this over the years is you really often get 6 or 7 months into it before you really see how well the person is going to do.
As I said, I think the issue really is about staffing and having, I want to make sure that we have everybody on board that the grant pays for before we really jump with both feet in, so to speak.
For the AOT pilot, I think we've been part of it since last fall. We have 3 positions in the pilot. We have filled one of them, which is the licensed, kind of the lead person. And we have an LPC filling that position. She started on Friday, July 1st. I'm sure y'all know it's difficult to hire all across the state, and this program has been no different. We've been advertising the remaining 2 positions for months, and we've had no applicants, I'm afraid.
In terms of thinking about it from a statewide perspective, if you're in a rural county, probably some of the initial involuntary treatment orders are probably going to come out of either crisis stabilization units or state hospitals. So there is going to be a need for judges in, say, Gilmer County or other counties to build a rapport with the more restrictive institutions that might be where some of the individuals are being identified as being eligible for AOT?
We have 3 that we have gone to court on since the pilot started. We have 1 more who is scheduled for court on July 20th. We have 1 person, she was our first person, I believe court was like December 30th, December 29th. It was between Christmas and New Year's. She's had 1 brief hospitalization. I believe that was in January. And since then has done very well, and I think is working part-time.
Well, actually, last Wednesday, we had, at the request of the individual that's subject to the outpatient commitment order, she requested a status hearing. And we were able to review how she's done since she had been released from the crisis stabilization unit. And while she still probably doesn't have full insight into her mental health issues, we are making progress towards her getting stable housing. Things are not going to be linear. They're not going to be in a straight line. We're going to have ups and downs. People are going to, with every individual, no one is able to be perfectly consistent all the time. To the extent that AOT helps with consistency, that's very important.
Okay, that's great. Carol, please continue when you're ready.
Thank you. So we felt that it was really important to kind of hear from the boots on the ground instead of just kind of me telling you about the program, but to really hear from those that are really doing the work. Here's a list of our current AOT Advisory Committee members, which include representation from the court, provider, from the department, and from advocates. The committee members have been very vocal throughout our meetings, and we've really enjoyed a good working partnership. And we've received a lot of feedback from all involved, and that has guided some of the work that has been done. Judge Harris, who's here, is part of our committee. In thinking about the committee, we may benefit from engaging law enforcement as we continue to do that work. So the AOT Advisory Committee reconvened their meetings in June, and we're meeting every 2 weeks, and we're focusing on the creation of reports, both to the court and for programmatic purposes, a timeline for clinicians to follow that provides guidance as to when to submit their report or when to request court interventions. We're working on a visual process flow of the AOT process and the data collection items that were discussed earlier. Discussions are also being held on build requirements, the bidding process for the new sites, and discussions on AOT consultants and evaluation. These are some of the implications of the bill as it relates to AOT. So the bill created a 3-year grant program to establish the efficacy of the model, and it provides an AOT definition and outlines the application process for the grants. During these 3 years, DBHCD will provide training, technical assistance, and oversight to the grantees. And the grantees must be a collaboration between CSBs or a private provider, the court, and sheriff's office. And the funding is a little over $2.2 million. So here, HB 1013 defines assisted outpatient treatment as involuntary outpatient care provided by a CSB or private provider in collaboration with community partners to identify participants, to establish procedures, provide treatment, establish effective communication between the court and providers. And we've really kind of honed in on that, partnering with law enforcement for diversion strategies and maintaining an individual's connection to their treatment. So main takeaway is that this really isn't done in a vacuum, that it is truly a collaboration between various interested stakeholders. Here are some of the deadlines from the bill. So in October 2022, the funding announcement needs to be out. By December of this year, 2022, we need to announce the awardees for the grant. And prior to awarding the grants, we have to contract with a third-party organization to evaluate the program and the effectiveness. In January of next year, that's the deadline to actually commence the funding, the technical support, and the oversight. And by December 2025, we have to evaluate the effectiveness and the consequences of AOT and submit various reports to the Governor, Health and Human Services Committees of the General Assembly, and the Office of Health Strategy and Coordination. So this is where we are with the process at this time. Internally, we've started conversations about the development of the AOT grant to include the grant language, a timeline for the rollout of the grant, and discussions on contracting with a consultant and an evaluator. DBHCD staff met with the Treatment Advocacy Center to discuss a possible scope of work and contract as a consultant. And then this information was provided to the advisory committee. And on July 5th, they approved the use of the Treatment Advocacy Center as the grant consultant. So there are some challenges that have been identified related to AOT that are listed here, and you also heard echoed by Dr. Patillo and Judge D'Antonio in that interview. Low enrollment can be attributed to workforce shortages. Dr. Patillo stated that she didn't get any applicants for 2 of her positions, and it wasn't until the beginning of this month that she really got that lead clinician in. Prior to that, she was the one doing the work. And without the staff, we really can't provide the services. Judge D'Antonio himself stated that, he wants to have the appropriate staff before they fully jump into AOT with both feet. Throughout the rollout of the pilot, there's also been difficulty in finding willing sites to participate in AOT, both from the behavioral health and the criminal justice side, which is why we've recently just identified Judge Chastain from Gilmer County as the next site. And during conversations with Judge Chastain, the need for additional funds for the probate court to be able to hire staff to attend the additional hearings, have constant contact with providers, and provide legal representation was brought up as a challenge. So these are part of an ongoing discussion internally and within the advisory committee, and some that we plan to tackle through the work of the consultant. So where there's challenges, there's also opportunities. So one of those is participating in this forum and collaboration and input from this committee. We have opportunities to provide education and build rapport with judges. Judge D'Antonio is a great example as he welcomes other judges and interested stakeholders to participate in his AOT hearings. We have the opportunity to create a sound AOT program that focuses on the efficacy of services and the standardization of practice. And we have the opportunity to increase public awareness about AOT, that this is a service that it's put in place with a goal of increasing the participant's ability to remain in the community, live a stable, healthy life, and really work towards their path to recovery. And with that, I'd like to thank you for your time, and I'm happy to try and answer some of your questions.
I wanted to just briefly address the low enrollment piece of this, Carol. I'm wondering, are there any statutory changes that you would recommend that we make in order to allow you to have greater enrollment? For example, do you find that the statutory criterion starting in line 929 of the bill appear to be overly restrictive? Those seem to have come from California code, and we're not exactly sure how they appeared in the final bill, but it seems to me like they could potentially restrict the flow of people in from CSUs or from state mental hospitals. I mean, has there been some thought on the department side to whether or not the criteria needs to change to increase the flow of people into the program?
So if with the conversations that I've had, Judge Amero, that has not been brought up, and I'm going to lean into Monica to help me answer this question. I can tell you that from Dr. Patillo and from the perspective that she's provided to us, they have individuals that they're ready to enroll, and their main issue has been more towards the staff shortage than the inability to find eligible participants. Monica?
Yeah, thank you. I did want to lean in there. So I think it's a good question, Judge Amaro. Right now, we're really focused on trying to implement as it is outlined in the bill. And then as we learn through this process and we get the consultant on board, we get additional sites in place, we'll just know more information. And so we'll be in a position where I think we'd be better able to say or provide some either concerns or recommendations. But right now, we're really focused on trying to just implement what's in the bill as is at this point in time, recognizing that we do have some of the challenges that you heard expressed earlier.
Well, one of the ways in which we can help as a subcommittee is to make recommendations that could potentially revise this criterion, for example. So what we'll be looking for from you is any sort of statutory change or funding increase that you think would be necessary to make this program work. And so hopefully you'll be able to give us a readout on the problems that you see as we move along.
Sure, absolutely.
Absolutely.
Is there anyone else on the commission that has a question for the?
I have a couple of questions.
Go ahead, Nora.
Okay. So there are going to be 5 pilot sites. Is that right?
So there's going to be 5 sites per the House bill. We have 2 pilot sites that are federally funded through the ARPA grants. So one that's actually working right now, which is Judge D'Antonio and New Horizons. And then there's going to be the additional sites that are going to come forth with the funding from the bill.
So there'll be 7 sites, 7 AOT sites.
So 5 total right now, including the 2 pilot sites. So the 3 additional from the House bill.
Okay, so the 3 other sites, they have RFPs and they will be selected, 3 sites, right?
So we were going to go through the grant application process for the sites.
Okay. And then my other question was in your presentation, which was very nice, and thank you so much for that, was the treatment team. I know some AOT sites, and maybe all of them, I'm not sure, use ACT teams to provide the services. So, and I think the bill, but I'm not sure, I'll have to go back and look at it, says that the case management will be provided by a team that is evidence-based. So what kind of case management will we be using for those sites?
So as far as the ACT services, so ACT services are a potential service that could be available to individuals if that is the service that they need. But we're going to have the team that I was mentioning, the clinician, the case manager, and a peer. It's really going to be dedicated to this process and really be able to help the individual navigate through the court process and then help get them linked to the services and be able to communicate back and forth to the court and really link them to those other services, whether they need, let's say, intensive case management services or things like that. If they need, I'm thinking of our residential placements, they'll be able to link individuals to those services depending on the needs that are identified in their recovery plan.
So those 3 professionals will be able to hand them off to different case management teams. Is that right?
They should be able to link them to all of their necessary services.
Okay, thank you.
You're welcome.
Judge Harris, do you have any questions that you'd like to ask at this time?
Yes, thank you. First, I want to say it has been a pleasure to work with Carol because she understands AOT and has experience in this field. And Monica is my personal go-to person. So I do appreciate her. And I want to say that because I know there are a lot of higher ups in DBHCD on this. So I do have a question though about the funding piece. The slide that you showed that talked about the funding from the ARPA money, that's how it's broken down for those one existing site, one that's coming on. Are there restrictions on how the grant money, the appropriation to the grant money from the bill from 1013 that will impact a grant application? So for example, if a grant application is made and they say we need X amount for 3 years or whatever for a clinician, for the peer support, and we also need somebody for the courts, or are we going to build in funding? One of the questions I've heard from the CSBs or providers, can we build in funding to pay for our lawyers? So their lawyers representing them in court, representing the provider. I really just am trying to get a handle on any restrictions on the funding.
So it is my understanding that there's no restrictions in that budget other than the expansion of the sites. But Monica, is there anything else?
The only thing I'll say about that, in addition to what you just said, is that the budget is the budget. And so there may be an ask, or somebody could come back and say, well, we actually need more than what's allocated. So the budget is the budget. So we have to work within the funding that is available. So I think that's just an important undercurrent to the conversation. And it's a part of the procurement process, the bidding process. We get budgets and there's a conversation or, some back and forth about that to make sure that we are within the budget that we have to work with. So I don't know if that answers your question fully.
Well, I think so. I guess what I'm getting at is that I know that under the SAMHSA grant and the ARPA funds, so the people that don't know this, the ARPA funds came through a SAMHSA grant. So I know those funds are limited only to people. So they can't be used for anything else.
Correct.
And so I guess that's what I'm getting at. Are the funds that are coming through the appropriation on 1013, are those only limited to the clinician people? And it sounds like you're saying no.
Yeah, so
they may be.
And I don't have it in front of me, so I want to say it with a caveat that as far as I'm recalling, it won't have the same limitations that the federal funds have. Right. The federal funds are from SAMHSA, but via the block grant, and the block grant has a enormous amount of requirements and rules and how those funds can be used. And you outlined it correctly. It has to be specific to treatment and people. Right. There's a little bit more flexibility in the other pot of funds, but I would want to have that language in front of me to make sure that there isn't some caveat that I'm missing.
Sure.
But yeah, there's definitely a difference in the flexibility.
Yeah.
Monica, can you send us a final answer on that by way of email? Post meeting?
Yeah, if the answer is different than what I said, I will absolutely. But for now, I think there's not the same rigidness that is associated with the block grant. But I will double check that and then confirm that back to you in email.
Yeah, I think that's an important piece for the CSB, from what I'm hearing from the CSBs, providers, and the courts. That could be, it may be numbers wise, it may only end up being those employees, but I think that's a factor that would be important for them.
Right.
Let's just take another 2 or 3 minutes for questions, maybe one more question, and then we can shift to the next presentation. I know that Monica needs about 30 minutes to do her part. Any other questions?
Just real quickly, it seemed like there wasn't much information on the data collection portion of this. Is that still kind of up in the air a little bit?
So we have some data points that we're definitely looking at, interactions with law enforcement, days in jail, and we have various reports that we're working on that we're building within our advisory committee, and we're utilizing our pilot sites to to start using this report, start gathering some of that information, and then tweaking as we go along. I don't think these reports are written in stone at the moment. And we really want them to inform our process and then really be able to evaluate, like, are we being effective? Is there any changes that we need to make based on these points? So it is something that our committee is working on. And currently we're reviewing a multitude of forms.
I know there's one of the presentations coming up real quick about, it has a lot more data in stuff, but, I'm thinking that if you have low input on the grant, there might be some hesitancy on some agencies for data collection issues. If you could pick sites that had the same jail database, that would help y'all maybe. I don't know. I'm just throwing that out there, but.
Thank you. I appreciate that, that recommendation.
Maybe we can hear a little bit more from Stephanie Lopez Howard later on about this topic as well. I am also very curious, Carol, about whether or not you've looked at 2 other states and their examples for how to approach the data collection piece, but perhaps that's for another day. Maybe we can get you back here, let us know how this process is going about a month or 2 from now.
Sure, absolutely.
Okay,
Judge
great.
Amaro?
Yes. Hey, Carol.
I have one question. I want to know about the how clients or how individuals are going to be selected or referred to the program. What's the funnel? Where does that start? Who chooses who gets to go into the program? I mean, obviously they have to go to the probate judge, but how do they get there? Where are those referrals coming? Coming from the community, coming from the jail? Where are those referrals coming from?
So right now they're being identified by the actual provider. And Dr. Patillo kind of alluded in her interview that, she's got individuals that she wants to put into the program. And it really is for those individuals that are identified as just, and I'm going to use the term familiar faces, of just kind of cycling in and out of the system and really, kind of stuck in that revolving door. So I believe they're looking at those that have a high number of inpatient admissions that's within that community, within the New Horizons Committee, and then they're putting those through the program.
So one question I'd have is, would DBHCD's hospital system be able to refer? Because providers sometimes don't want to work with certain people. Some of those high flyers are very difficult too. So how do we guard against that bias? How do people who may need it, their provider may not want to work with, how do we get those people, focus on those people who are in the jail, who are in our state hospitals, who may not be with our CSPs at this point?
So I believe that Judge Antonio is already working with hospitals and providing some of that education to reduce some of that bias. I do understand, and I do believe that it happens. And I think that as we expand our sites and, we kind of try to roll this out through the state, we're able to, reach out to more individuals that really need this, that may not be just identified in this small pilot.
All right. Thank you, Dr. Bailey. That's a question obviously draws upon 30 years of experience with the department. Let me see. I have more questions, but I think that I'll ask them offline. One of the things that I've noted from my review of the literature is that more than 80% of the people that go into AOT programs in other states are coming out of the state mental hospitals. And I'm a little bit concerned about the ability with the statutory language, the way it is with the admissions, I should say the eligibility requirements, the way that they are, that you may be getting fewer referrals from the state hospital, and that seems to be the natural place for these sort of step-down services. In any event, that's something that we'll be keeping an eye on. Let's shift now, if we can, to Monica Johnson, who kind of give us an overview of the other services provided by the department in this space.
Thank you, Judge Amaro. If I could have a little bit of grace, I do want to add one more point about the data for the AOT. We are also responsible for getting an evaluator for the program. So we're going to be procuring or bidding for an evaluator. So for another entity to do the analysis of the program. So the data monitoring, collection, and what that means for the program. So it's an important piece that I didn't want to get lost. So thank you for that. We'll transition. So Carol is the director for the Office of Adult Mental Health. She works on my team. I am the division director for behavioral health here at the department. As a part of the Monica Johnson retention plan, as you heard about workforce challenges, I dare not make Carol do both of these presentations. So I'm leaning into the Office of Adult Mental Health, wearing her hat as well as mine today. So give me grace. I don't live in the Office of Adult Mental Health on a daily basis, but I've been here long enough to be able to navigate this pretty easily. I've been with the division or with the department for, it'll be almost 12 years in November. I'm a licensed professional counselor by trade. Prior to coming to the department, I've worked in a variety of behavioral health settings in the community, inpatient and outpatient, and have been working in behavioral health for 26 years. Yes, I started when I was 10. So we'll go ahead and get started. I'll give you a quick overview with the time that we have today. So just a quick reminder of kind of how the department is set up. I won't spend a lot of time here, but we're broken into 6 regions. We have 23 community service boards. We have a statewide Georgia Crisis and Access Line. We have statewide mobile crisis services. You see our hospitals listed at the bottom here, and then some of the community crisis network. And I'll touch on some of this later in the presentation. Next slide. Our department as a whole, if our FY23 budget is $1.38 billion, we have approximately 5,300 staff. Most of those staff are hospital staff that work in one of our 5 hospitals. We have for approximately 256 behavioral health providers. I actually think that's exact as of maybe 2 days ago. I did the actual data pull for that. And then the other things I touched on. So we're going to move ahead for time. DBHDD was created in 2009. Fun fact, I came in 2010. So very familiar with the department. It was created as a result of a Department of Justice federal agreement. We provide treatment and support services for the most in need individuals with mental illness, substance use disorders, and IDD, intellectual and developmental disabilities. Our priority population are individuals who are uninsured, underinsured, or receiving Medicaid that is not necessarily managed care Medicaid. So often referred to as Social Security or SSI disability Medicaid, please. So I'm going to drill down to Division of Behavioral Health, and then I'll drill into the Office of Adult Mental Health. So within the division, we have responsibility and accountability and oversight for a variety of areas. Adult mental health obviously being one, and adult mental health is one of our largest offices and books of business. Children, young adult, and families, addictive diseases, crisis coordination, which is not just about behavioral health, it's an enterprise function, but just sits in behavioral health. Deaf services, which is really about increasing access for individuals with mental health or intellectual developmental disabilities, and they need access that are access to services that are culturally, linguistically appropriate. Recovery transformation, certified community behavioral health clinics. We have an office for prevention, mental health promotion, federal grants, supportive housing, disaster preparedness, and then oversight of the behavioral health staff that are in our 6 region field offices. So we're a pretty large division. Next slide. So we are the only division out of the DBHDD 3 disability areas, our hospital division services, behavioral health, and IDD. We're the only division that 100% contracts out the work to a network of providers. We do not provide direct services out of any of our offices. So our provider network, the number that was on the previous slide, is broken into 3 categories, and we call them tiers. Tier 1 is basically our community service boards. This is our most comprehensive net provider type. The CSBs, as you know, are written into statute. They are Medicaid funded, state funded, and many are on private insurance panels as well, et cetera. Our tier 2 providers are Medicaid only providers. They do not get state dollars from DBHDD to provide traditional outpatient, what we call core services. And I'll talk a little bit more about some of that language. And then we have tier 3 providers, which is a group of specialty providers. There are some services that you can offer as a standalone or an a la carte service. An example of that could be ACT, assertive community treatment that was referenced earlier. Sometimes you are a provider that only provides that service and that's it. So we do have a la carte providers. Next slide. So now we will dig down into Carol's office, the Office of Adult Mental Health Services. So this is a list of services that Carol is responsible for. She just gave a pretty robust presentation on AOT, which is one initiative out of a plethora of other services and responsibilities. This list is not necessarily even all inclusive. I did not include some special projects or newer initiatives that we have not quite fully baked yet. So I won't read this list to you. I will point out, though, the asterisks next to some of the services. The asterisks indicate that these were services that were required as a part of our federal Department of Justice agreement. For those that may not quite know everything about that agreement, the most important thing to note is that the impact it had on community behavioral health is that we were responsible for building out a more robust community-based system of care for adults. The agreement did not impact children, but I have been able to sit here for a while now in a variety of roles in the department and see where we came from 2010 to where we are now and get an opportunity to talk to other states. And Georgia does have a lot of community-based services. We have our challenges, just like every state, but people are often surprised at what is available in this state, in the community. So, yes, sir.
Just a real quick question here with respect to these services. How do you, people with severe and persistent mental illness who end up in jail, do we know how many of these touch points they have had prior to their incarceration or as part of their cycling in and out of hospitals and jails and the community?
In some instances, the answer is yes. It would be at the provider level, though. So when I worked in a community service board, I would know the individual that may be on any of these services because we do collect data on, have you been in jail or prison in the last 6 months? That's a question that everybody has to ask as a part of our data set.
Has this data been aggregated and made available in the report?
No, that does not exist right now.
Okay.
There are some programs in which we can pull and lean into to get more information. Some of those programs are like our housing voucher. We do have information about where they were they in jail? We do have those data sets, and some of those are reports we can pull. But like, do I just have that on demand? No is the answer.
Okay. And do you know, like, for instance, let's say, for instance, I'm a familiar face and I have my first touch point with you is with intensive case management for whatever reason. Is there ever any effort to sort of follow the person to see where they go next?
So yes. So we have some. Can we come back? Can I hold that question? Because I think I'm going to address it in a different slide.
Definitely. Yes.
And then I do want to make a note because we do have multiple ways in which we do that. And I want to talk about it fully. So thank you for that. So in any event, I did pull out a couple of these services from this list. You're fine on this slide. I did pull out a couple of services that I did want to dig a little bit deeper into because they're usually the ones people ask about. So assertive community treatment, that was referenced here earlier. It is considered the linchpin for community adult mental health services. It is a 10-member team of individuals that wrap around a person. That team consists of a psychiatrist, a nurse, a therapist, a licensed therapist, a case manager, a peer, a certified addiction specialist, and so forth. So it is a very robust team that wraps around these individuals. It used to be called, people would reference it as a hospital without walls. I don't like to call it that because a hospital is a hospital, and this is not what that is. So, but it is very robust and it's very critical for our system of care. So there are 26 teams across the state. The target population is, they have to meet basically our settlement criteria, which is severe persistent mental illness, have some history of homelessness, in and out of hospitals, incarceration, et cetera. And the goal obviously is to use a multidisciplinary approach, hence why the number of people on that team, to keep them in their community. It's recovery oriented and very person-centered. Next slide. Intensive case management is another DOJ settlement required service. This is basically case management on steroids. It is case management by team. And so it is we have 16 of these funded across the state. A team can have up to 10 case managers and a lead on those teams. So it really is very intensive case management on steroids. Again, very person-centered. The goal is to keep the individual within their communities, and it can be combined with other services as well. Next slide. Here's just a quick reference. So if you're interested where these teams are, so we've just listed the providers, and we do have this service in every region except for region 4. Next slide. I pulled out mental health treatment courts just because of the nature of the conversation today. In the division, we have a combination of accountability courts. We have substance abuse courts, as well as mental health treatment courts. Only focused on the mental health treatment courts today. There are 7. Obviously, most of you will know what these are, but obviously geared towards reducing criminal activity, improving the stability of the individual, and acts as an alternative to incarceration for persons with serious and persistent mental illness, et cetera. So here is where these are located. We have some in regions 1, 2, 6, the providers that we're funding for this service.
Monica, are these people under sentence, the ones who are participating in the mental health treatment courts?
So they must consent to treatment. I do not know if everybody participating in an accountability court is under a sentence. I don't know the answer to that right off.
No, this is support that's being given to mental health courts.
Correct.
I'd want to make sure that this is not the same, because there are far more than this number of mental health courts that are managed through the Council of Accountability Court judges.
Yep, these are the ones that DBHDD funds, and we're funding the provider. So our money doesn't go to the court. Our money goes to the provider, and we do have a partnership as well with CCJC to get some of these funds in other hands as well. Some of that money, I do believe, goes straight to the courts.
So, all right. So these folks are the traditional mental health courts, and you're providing a funding piece to that and some support through staff to that as well.
Correct.
All right. Thank you.
You're welcome. Peer support is a very important service for us as well. Peer support can be done in different ways, individual, through group. We have a wide variety of different types of peers. Peers fundamentally just means individuals with lived experience who are living lives of recovery, and they come back and they help other individuals. People benefit from engaging with individuals that they can connect with and that they feel like have relevant experience. If you're a cancer survivor, you are interested in being around people that have survived cancer. It's the way we are as humans. We have invested heavily in our peer support network throughout the state and have been known on a national level around the work we do with peers. Right now, we have 2,345 certified peer specialists. We also have peer specialists in our addiction world. I did not pull those numbers. And then one of our darling programs is our forensic peers. And currently we have 145 forensic peers. Forensic peers are individuals that have been involved in either they've been to prison, they've been involved in the system and have a mental health issue and go through our training and are able to go back and help and support others. That initiative is done in partnership with the Department of Corrections, the Department of Community Supervision, and Georgia Mental Health Consumer Network. We're very proud of that work. Next slide. So we have a robust crisis system in Georgia. We have been building this out for over a decade and will continue to do that even more so over the next several years as we implement the 988 number, a new 3-digit number that goes live tomorrow where people can call to get access to support. In Georgia, that'll mean they'll call our GCAL line, our Georgia Crisis and Access line is where they'll be connected to. But we have crisis supports through what we call behavior crisis centers. The acronym for that is BHCCs. These are basically entities that have bed capacity for an individual needing short-term crisis stabilization. Average length of stay may range between 5 to 7 days for these, so short-term stabilization. In addition to the beds, there's 24/7 walk-in access. So you can just walk in if you're in a crisis and get that type of assessment. And then we also have what we call 23-hour observation. So this may look like a lounge chair. It could be something in that nature where someone does not need to be admitted to a bed, but they need to be under observation for a short period of time. Judge O'Mara?
Monica, to what extent are these BHCCs, the crisis stabilization units, linked with local criminal justice systems, courts, police departments, actors, sheriff's departments, actors of that sort?
Yeah, so I believe if you ask any of the community level individuals, they will say positive things about their local behavioral health crisis center. I think the sheriffs would say positive things mostly. I think that the communities feel the impact of these behavioral health crisis centers. When I have gone to visit them and talk to stakeholders, they are spoken of very highly because they can divert individuals from going to an ER. Right. What I hear most of is people would like to have more of these as many places as possible. But where they are and where they are invested in the community, and the community is aware and the agency is working to make sure that level of awareness is in the community, we do have very positive feedback about the operation of these.
But you have MOUs with police departments or with court systems that
not for the
specifically. One second, please. Let's speak specifically about the relationship between the local systems and the BHCCs or the crisis stabilization units. For instance, is there some kind of a protocol that's put in place for when somebody in a crisis could be brought to such a place as opposed to an emergency room or a local jail? Do you have any formalized relationships and MOUs with any local actors who are in the criminal justice system?
So there's a couple of
questions. Can I help answer to clarify that? Because I know where Judge O'Mara is going, and I think I can clarify the question. I think he's referring to placement. So when you have a crisis and law enforcement gets involved, who does law enforcement contact? And I think what he's alluding to is having to deal through GCAL and going through that process. So you might explain the process of what does law enforcement do? Who do they call? What's the protocol there?
Well, actually, Sarah, it's true that I'm interested a little bit in the way that you've approached it, but I'm more generally concerned with exactly whether or not there's any MOUs that have been created between these BHCCs and the local actors like sheriff's departments or police departments or court systems. has there been any kind of formalized arrangements about who should be taken when a police officer stops someone who has severe and persistent mental illness? Is there any formalized arrangement between these entities and these units? I think the answer is no.
Well, I'm going to answer the questions I think that I heard. So
okay.
we do not require a MOU to be had in place between the provider of the BHCC and law enforcement. I am unaware of any MOU that exists between a BHCC and a law enforcement entity.
So any partnerships like that have been formed between police departments and BHCCs?
So if there are partnerships, then that would be a local entity. So we recently saw an example of that in Chatham County. So we know that in Chatham County, through their Familiar Faces initiative, their BHCC is a partner with the local police department and other stakeholders. And the BHCC is a central part of that. That BHCC is operated by Gateway Community Service Board. So there is a local collaboration in that example. In any of these BHCCs, all of which are operated by a community service board, except for one, which is in Columbus, that is operated by a hospital system. But all of them have the ability to enter into any type of community collaboration. We don't require that, but we do encourage that they are connected to their community, with one of our important key stakeholders being their justice involved individuals. So courts, sheriffs, judges, whomever in that community they should be connecting with.
So you're open to further collaboration between local criminal justice systems and these units so that there's additional access to these types of beds?
Absolutely.
Okay. All right. Thank you. Please continue.
Can I follow up on that? So just to be clear, do you have the authority to require that of the BHCCs?
To require MOU or to require
no, just to require collaboration.
We already require that they are collaborating and that these are the stakeholders in which you should be engaged with. So that is already an expectation that we do have in place.
And if that's not happening, is there a procedure for DBHCD to get involved to encourage that?
Yes.
Okay. Thank you.
You're welcome. We're good, Judge Amaro?
Absolutely.
Okay. All right. So I'm going to go through this really fast just for the sake of time. I'm watching the clock. So provider network management. So as I said earlier, we don't provide direct services, but we do provide oversight for our provider network. We have what is called an ASO. It's an Administrative Services Organization. That is an external partner to us. Some people say, is that managed care? It's not managed care. It's like a care management organization where it allows us to take care of administrative services, like how people get authorized for services. Our crisis and access line is housed through a partnership through our ASO collaboration. And Beacon is the name of the ASO. So through that infrastructure, we provide several functions of oversight. The one I'm highlighting today is quality improvements. So we provide on-site reviews of providers. We look through client records. We look through policies that the provider has, and they are scored. We look at billing trends. We look at a number of things so that we can have a level of understanding of what the provider is doing and how they're performing to try to make that as succinct as possible. Next slide. This just kind of goes through more of what happens as a result of the quality reviews. These scores are published. If there are negative findings, there is a process, an escalation process of what happens there, depending on what those findings are. We look at that data, we make recommendations based on that data, and there may be also corrective action plans put in place as a result of some of the information that we find. Next slide. This just really talks about the tool and kind of what we're focused on when we go to do these reviews. Whole health, safety, community, person-centered practices, rights, and choice are some of the areas in the tool that is used for these quality reviews. We look at billing validation. Did you do what you said you billed for, that kind of stuff? And does it look like the treatment planning and the assessments line up appropriately with best practice and expectations? Next slide. Other ways in which we provide provider network oversight, and you'll get these slides if you haven't already, you'll have these slides, and I've included some hyperlinks where you can go and look if you're interested in ways in which we do some of this stuff. But for our non-intensive outpatient core services, which is pretty much think about going to the doctor. So psychiatrist, nurse, case management, therapy services, et cetera. We do monitor key performance indicators. Providers are required contractually to submit data to us every year. That data is submitted through a portal that we've created. It's been in place for about 7 years now. And we look at things really about access, how quickly providers are responding to individuals that come to them in crisis. There's a slew of data points that we're collecting. And at the core of it is really about assessing, are they meeting some standard performance indicators that should improve an individual's experience and access to services when they need it? I'm
sorry to interrupt, but
is
criminal justice involvement of X number of participants that are the people that they see at all included in the data points that are collected in this?
It is not included in this particular data set, but this can be updated. Like, we look at it every year. So if some of the recommendations that come forward are, we would like to see more of that, this is something we control and manage and could definitely add those type of data points.
So for instance, if you have 100% of the people in your program that are if the provider is 100% complying with the model, they're showing complete fidelity to the model, but you have all of their participants within 6 months are ending up in the local jail. And is that something that you measure right now or that you see right now? It doesn't sound like it.
It is not a data point that we currently collect.
Okay, thank you.
You're welcome. And then we obviously are responsible for contract management. There's lots of deliverables depending on what the service is in the contract. Providers are required to do programmatic reports. Providers are required to have a national accreditation. And so I listed one of the more popular ones if someone is interested in seeing what that accreditation means and the robust nature of what the provider must meet in order to be accredited, to be a provider in our system. And then we have obviously a robust provider services manual. I knew I would not have time today to hit on every service, but if anyone was interested in the services that was discussed, the link to our provider manual is there. You would just put in the service you're looking for in the search box, and it would pop up once you get to the site. Next slide. There are certain services in which we do have fidelity monitoring for because they're evidence-based practices. So Assertive Community Treatment Act, we do have a fidelity monitoring team that does follow the fidelity monitoring guidance, and that is still active. We do the same for supported employment. And then we are now implementing the same for supportive housing. And I meant to mention earlier for supportive housing that currently right now, DBHCD funds 1,834 individuals in a housing voucher. So those are for individuals that they get tenancy rights, they have their own apartment, and we help supplement the cost of the rent. So that's a pretty robust number. And then the last thing I put here, we do require, go back one slide, please. We do require that all providers complete certain assessments on individuals coming into care. And this is one right now that the state does require, the adult needs and strengths assessment. Really looks at making sure we have a standard way for individuals coming into care to have their clinical needs appropriately assessed and then put into the right level of care or connected to the right level of care. Next slide. That was a lot of information, and I do understand that. We're happy to come back as many times as you want us to drill down into whatever area you would like, but our contact information is here. So any other questions?
Well, that was extremely helpful, Monica. Thank you so much. Anybody on the
I have
committee
a question.
has questions?
I
Nora.
do. Monica, could we go back? I think it's slide 29, but I could be wrong.
Hey, Nora, how are you?
Hey, Monica, you're looking cute with your blue glasses.
I was admiring your staircase.
Thank you. Well, the question I have is that, it must not have been 29. Yes. Okay. My question is, all these services are for people voluntary. Is that correct?
Correct.
So how are we going to fit in with AOT when it's not voluntary? How will they be able to fit into any of these treatment modalities?
So while these are voluntary, what we want to do with any service and with any individual is to do motivational interviewing to make sure that we are encouraging and outlining what the benefits are. People do have individual rights and can say, I don't want that service. A good clinician or a good provider will keep trying to get to the yes. And if you don't want this now, are you willing to try this? And so you're right. People can say, no, I don't want that service because they do have that choice. But we should be encouraging, and a no should not be a deterrent the first time or the 10th time.
So if one of our participants gets an order from the probate and it looks like their best place for service, let's say, would be an ACT team, and I'm just using that as an example, and they say, no, hell no, I'm not doing that, then what would happen?
I think Sarah's got a comment on that.
Oh,
Sarah?
sorry.
Sarah?
The court can order that they participate, because part of the process to go into involuntary commitment, either inpatient or outpatient, is that the provider working with the individual creates an individual service plan. The court then essentially approves that plan and says, this is what you do. So my orders will say that you participate in the plans and the recommended treatment, et cetera, et cetera. And if you don't, you're in violation of that order. So then you got to come back to court and we've got to talk about why you're not participating. And there can be a change in the plan, but the court can order that that plan be enforced.
All right.
I really do think that this is also where it's crucial for that team, the AOT team, to kind of come in and lean in. That's what they're there for. They're there to engage the individual, motivate them, and really work with them more on a one-to-one, basis to get them into those identified or needed services. So that's really why we're, really, I'm excited for the work of a peer who has that lived experience to be able to kind of handhold this person and really explain to them through their lens as to why this is important.
Before we move on to the next topic, I just wanted to touch base with Dr. White and Dr. Bailey to see if you have any questions or comments before we proceed, because you guys are in this space and have been for a long time.
Judge Amaro, could I ask one quick question?
Sure, and then we'll go to Dr. Bailey and Dr. White.
Okay, I have I'm just curious. This is kind of a political question. I thank you so much. I've been in the court system now 36 years, but I've still learned a lot from your slide. And unfortunately, the bureaucracy of government sometimes gets to be a little overwhelming. And I just got through with United Way meet. What is the cost of DBH DBD versus the services that go out? So I know y'all fund most of all those organizations, the CSBs, the ACT team, all that kind of stuff. Is it like, is the state agency 10% and 90% goes to services? I'm just very curious, and I figured might not know the answer to that.
So it depends on the service. In most cases, they're billing Medicaid or a payer for their services. And then
I'm really concerned about, just curious about the fact that DBHDD is an agency, is your, and I'm saying, because y'all don't do any direct services. So what does it cost the state of Georgia to administer all these programs? Is that a 10% to fund, all the staff and roles, and then 90% goes out to these programs, or is it 25, 75? I just don't have a clue. I'm just very curious.
I wish I had that exact number with me, but I don't. But we do. But we provide robust funds. So some things are just.
But 1.3 billion is a lot of money.
Well, that's for the whole department. Yeah, that's for the.
But how much of that is actual services, and how much of that is not that it's not needed. It's not a judgment call. It's actually just a curiosity. Just from my own curiosity.
Hey, Judge, maybe we can take that up later, but maybe we can get Monica to send us any kind of report or documentation that she has offline afterward, since it doesn't appear that there's an obvious answer. Can we just shift now to the doctors? Anything from the doctors before we change gears?
What I wanted to say was that in forensics, for years, we used a variant of outpatient commitment. It was just through superior court judges rather than through probate judges. And that's the only way we were able to get people who are at high risk for hospitals out with monitoring. I love that, I love that Georgia's now really going to embrace outpatient commitment, so less people have to be criminalized. And so I'm hoping that we're able, that's why I keep focusing on who is the population pool, not the folks that the CSBs like to work with, the people that are at risk to being in the hospital, or the people that could come out of the hospital earlier if people were going to monitor them.
Right.
So that, because those are the people who then land up in the criminal justice system. So to me, how you just select, you can select people who are easy and voluntary versus the people who need outpatient commitment, to me, the most are the real hard people. And they land up in the forensic system and they don't need to if we catch them on the adult mental health system.
Are you on the ad hoc advisory committee, Karen? Sounds like we need you there. How about you, Dr. White?
The question I have is, especially as we think about access to mental health care services, and we're thinking about AOT, ACT services and intensive case management services are going to be highly sought out. Do we have an estimate of what the wait time is currently for individuals to gain access to ACT services or intensive case management? And then a follow-up would be, if they are placed on AOT, would they jump the line in that to gain these services?
Great question.
I don't really have a wait list right now on the teams as far as ACT services. We are experiencing on the ACT teams, just like with everything else, some of those workforce challenges as well. So we have to be mindful of the ratio. So I am asking the teams to kind of, if they're getting referrals and they're not able to access service immediately, to be able to engage them in interim services and make sure that they're being supported until they're able to get into the team. So I don't necessarily have like a wait list number, Dr. White, that I can provide for you.
Is there a way that you can get us that offline later?
I can look into it. We are experiencing, again, just the same workforce challenge issues that I think everybody else is experiencing. But yes,
you guys track the wait, right?
The teams are keeping track of the number of referrals that they are receiving, that they may not necessarily be able to immediately enroll. There is an engagement period that occurs with ACT teams. prior to actually enrolling somebody into services. So it's something that we can look into.
With Gateway, they seem to be very responsive on the ACT part, the slowdowns in the jail, if they're in jail.
Gateway has a full team. That is one of the few providers that actually has a
Well,
full
shout
team.
out for Southeast Georgia.
They're on top of it. Hey, Stephanie, you ready for us? I want to thank the department for their part of this presentation. It's been fantastic. Please go ahead, Steph, whenever you're ready.
Okay, so can I share my screen? Is somebody else driving? I was.
Oh boy. You're asking the wrong person.
Okay, it looks like I'm not getting any pushback from Zoom to share my screen, so I will share my screen. Okay, can folks, all right, so now you're looking at yourself, which is always annoying. Move this over. I'm going to go into presentation mode. And now you're looking at my follow-on, so let me just swap. And now you're looking at what I want you to be looking at. Okay, so hi everybody, my name is Stephanie Lopez Howard. I'm the Statistical Analysis Center Director for the state of Georgia. The Statistical Analysis Center is a division of the Criminal Justice Coordinating Council, which is the agency that manages on the criminal justice side, Edward Byrne Justice Assistance Grants. On the victim services side, we manage Victims of Crime Act money. Those are two of our biggest federal funds. And then we have the Crime Victims Compensation Program, and we manage administratively the funds that are allocated to accountability courts throughout the state. So we move a lot of money around. And one of the things that we also do as an organization, part of our enabling statute, is to maintain a portfolio of criminal justice research that informs policy. And we are supposed to be a criminal justice data clearinghouse. So I've been with CJCC for 12 years this August, which seems insane to me, but here we are. And I started as Statistical Analysis Center's director in September of 2012. I worked very closely on this research with John Spear at Applied Research Services. Applied Research Services actually is the first entity to really do any research with computerized criminal history data back in the year 2000 with a grant from the Statistical Analysis Center back then. We're a small but mighty shop. I've got a total of 10 staff, including myself. And we work on all kinds of issues. Part of what we do is support the data collection functions for the other divisions within the organization. We do reporting, and then we do some kind of like independent research and evaluation. So that's what this is. And it's funded in part with money from the Bureau of Justice Statistics. We are kind of federally recognized as the Statistical Analysis Center for the state of Georgia. There is one of me in every state. We vary in size and flavor and location. We are located within the executive branch of the state of Georgia. So what is this study? So a deputy commissioner from the Department of Community Health came to me one day wanting to know the percentage of people in jails who had psychiatric illness, because at the time the state was considering a waiver for Medicaid to help people in county jail with mental illness. My response was, who knows? There is no way to know. So we designed a study to try to estimate the prevalence of psychiatric illness within county jails. A little caveat, this study only uses criminal justice data sources. So we partnered with 9 county jails. We used computerized criminal history data, which is housed at the Georgia Bureau of Investigations. We used Department of Community Supervision's data, and we used Georgia Department of Corrections data. We wanted to look at measures within jail data that might help us identify people who have psychiatric illness. And we were using the flag within Department of Community Supervision, as well as Georgia Department of Corrections data if a person had been imprisoned and received psychiatric services or placed on an elevated mental health level, to determine whether or not someone might have mental illness. DCH uses an 11-point screener to identify mental illness for somebody on felony supervision. And the first goal of this study is to provide jail intake staff with a screening tool that they can use to identify people in their jails who might qualify for SSI, SSDI, or Medicaid by dint of having serious and persistent mental illness. We failed at that goal. I'll talk a little bit about that at the very end. The second goal, which I think we succeeded fairly well at, is estimating the percentage of the county jail population in Georgia with serious and persistent mental illness. So what did we do? We did a data mashup is what I'll call it, right? I've got 9 jails who were willing to be friends with me. They sent me data from their jail management system, and we brought those data in, we identified people, we cleaned the variables up, we sent those data over to Applied Research Services. They did some more magic and matched it to Computerized Criminal History, Department of Community Supervision, and Georgia Department of Corrections data. We analyzed it to look for prevalence, and then we did some advanced statistical work. I'll talk a little bit about that. And that is also kind of toward the back end of the report that was included with the email about the presentation, trying to figure out common characteristics in the jail data between people who have mental illness. So 9 jail participants, 3 urban, 3 suburban, and 3 rural jails. In 2018, which was the last year of jail data that we received, the active population in these county jails numbered 101,000 people. And in terms of the combined county populations of all of the counties in the study, we're looking at about 30% of the state's population. The active population of the participants' jails was about 1/4 of the total state jail population in 2018. As you might imagine, right, urban jails represented 55% of the total inmate sample, 39% were in the suburban jails, and then rural jails had represented about 6% of the inmates in the sample. Overall, what did the sample look like? In rural jails, the sample was more likely to be white than African American. Unfortunately, the way that race is captured in county jail data is not great. They are good at capturing whether somebody is white or African American. There's a whole lot of heterogeneity in terms of Hispanic, Black Hispanic, white Hispanic. Do you even capture Hispanic? Some other race, race unknown, and there's quite a bit of missing data on race. So really, when you look at these bars, right, the slivers are fairly small in terms of other races that are not either Black or white. But in the rural jails, folks were more likely to be white than Black. The split between white and Black in suburban jails was a little bit more even, and then in urban jails, the population is overwhelmingly African American. In rural jails, and basically across the board, actually, the population, male to female, is roughly 75-25%. Oh, no, I don't want to talk about it. Well, yeah, okay. So across all of the jails, right, the average number of booking episodes, regardless of mental health status, is about 2, just under 2 booking episodes per person. And I should mention and stipulate, right, that we're looking at people booked into jail. So this is not sentenced into jail, and this is not active population. This is just the turnstile. Every single person booked into the county jail over a certain period of time. So we took the jail data, we matched it. If you are arrested, right, you are fingerprinted. That is a biometric identifier. Some jails had the fingerprint ID, some did not. If you had a fingerprint ID, bully for us, because your match rate was much higher with computerized criminal history and the other jail data set and the other data sets, I should say. If not, John had to do quite a bit of magic to get matching to happen. You take the computerized criminal history file, you trim for the county where the person or the jail is located. You then further trim for the arrests occurring within the study period, and then you start to do your matches using a couple of different combinations, whether it's names, dates of birth, social security numbers, etc. Overall, right, we're not talking about a few rows of data here. It's a fairly large data set. We're looking at over 300,000 person records that we received, over 350,000 person records that we received. We matched about 71% of those person records. And we received over 600,000 booking episodes. We matched about 69% of those booking episodes. So a big data set. One of the things I was really interested in looking at was cell movement. Why my theory is if somebody is in psychiatric crisis within a county jail, they're pretty disruptive. They're probably moving them around a lot. That's probably a pretty good indicator of psychiatric crisis if we're trying to look at administrative data indicators. And I only got cell movement data from 6 of the 9 jails, which covered about 50% of the booking episodes. And unfortunately, if you know anything about statistics, if you're doing high-powered statistics and you've got a lot of missing data on stuff, it becomes a really kind of meaningless factor. So we found some interesting stuff on descriptives, but not anything that I could use for predictive value. So estimated prevalence of mental illness. And there are a lot of folks off camera, but the folks who are on camera, how often do you hear from the sheriffs that like half of the jail population has mental illness, right? Half of the jail population. Well, I want to talk a little bit about why that might be, right? Because of what we're seeing in some of the KPIs that I'll talk about, key performance indicators around people with psychiatric illness. But the reality from looking at this with a very conservative estimate, because remember, we're only looking at criminal justice data sets, right? And the criminal justice data sets that we are matching on are criminal justice data sets that require you to have a felony history. And I'll talk a little bit about what that looks like in the overall population. So caveats aside, we're looking at about 15% overall of all of the booking episodes involving somebody with potential psychiatric illness based on these screening tools. When you're looking at, close to 400,000 booking episodes, 15% is not a small number of booking episodes. And that amounts to about 9% of the overall sample, which is about 17,000 people. And that's just in 9 jails. So not a small number, 17,000 people over a 5-year period, about 9% of the total sample. But we're relying on a felony arrest history, right? And so 39%, so 162,000 or more booking episodes involve someone with no felony arrest history, straight up misdemeanors. 49% of all of the people booked, about 98,000 people, right, had no felony arrest history. So I can't say anything about the psychiatric status or whether or not they potentially had mental illness because they never show up in DCS or GDC data. What we can say, at least from the crop of folks that we were able to identify with the criminal justice data, is that they have twice as many arrests on average as someone without mental illness. And the number of arrests isn't like small, it's in the double digits over the 5-year time period. So somewhere between 10 and 20 almost arrests if you've got mental illness as compared to those without. Average length of stay for somebody with psychiatric illness overall, right across the 3 different types of jail, urban, suburban, and rural, is about 54 days as compared to someone without psychiatric illness or without the flag, which is about 26 days. And remember, this also is people who kind of come in and out even on the same day, right? So when you take averages, your low outliers pull the average down, high outliers will pull the average up. So this includes people who were there for a day and came out. People with the mental health flag stayed incarcerated in jails about 1.5 to 2.5 times longer than those without the mental health flag. In rural jails, interestingly enough, and this is actually something that surprised me more so because we hear often that folks in rural counties don't have places to go, and I'm wondering why there's some parity here. But they were roughly the same, people with mental illness and those without, in terms of the amount of time they stayed in the jail. What we call the criminal career length. So from the first time you are arrested to your current arrest, how many days total has elapsed? People with a mental health flag, about twice as long active criminally, being arrested criminally over the time period. Mean number of days, the people with mental illness in terms of criminal history here, more likely to have probation violations. And this isn't surprising absolutely no one, right? We know people with psychiatric illness have a harder time complying with probation. So they have more probation violations, and of interest, also more property offense arrests. Jail recidivism. So I talked about it a little bit at the beginning, but when you look at people with the mental health flag as compared to those without, on average, people with the mental health flag were booked about 1.5 times as often as those without a mental health flag. And for me, the more, I think, interesting indicator, right, and why you maybe hear sheriffs say that 50% of the jail population has mental illness, is people with a mental health flag were in the community about a month less than those without a mental health flag. So you're popping in and out of jail a little bit more frequently than those without a mental health flag. When you take those averages in terms of mean number of days between booking episodes, both populations on average are booked more than once a year. One of the other indicators that we wanted to look at is people with multiple booking episodes. So we have 5 years worth of data on people, right? 9 jails. What is the risk that any one person has more than one booking episode? And those with mental illness are twice as likely as those without, those without mental illness. It's backwards. Those without mental illness are twice as likely to have a single booking episode in the 5-year time period than those with mental illness. So those with mental illness are more likely to be booked more than once over a span of time. And this gets to, right, thinking about, there 50% of my booking episodes are covered with cell movement data. So thinking about disruption within the jail and moving people around, people with a mental health flag were moved around twice as many times within a jail as those without. So again, thinking about sheriffs saying 50% of their population and knowing kind of the unknown based on what we use to get to the mental health flag, people with psychiatric illness in a county jail are pretty disruptive. They're moved around a lot. They probably take up a lot of bandwidth. And so that might contribute to this perception that they make up a larger percentage of the jail population. And then the conversation about familiar faces, right? Which is really the population that is difficult, to Dr. Bailey's point, right? These are the folks that are tough to engage, that folks don't necessarily jump at the chance to work with. And what we found when I did a familiar faces analysis is all of the stuff that you see on the screen, but I'll try to walk through it. So first thing, what is a familiar face? So if you think about just one indicator of what we would call a familiar face, I see you over and over again, right? So that's the total number of booking episodes for a person. Familiar faces, and you take that booking episode count per person and you kind of create a distribution out of it, right? So that bell curve, you've got your central number, your mean, and then you've got 2 tails, one on the right and one on the left. The farthest most tail, which is your 99th percentile, which if you're taking the LSAT is where you want to be. And if you are getting booked into county jails is not where you want to be. Those are familiar faces, right? They are booked so many times, they're in the 99th percentile for total bookings. Those numbered about 2,000 people, just over 2,000 people were familiar faces. And of those 2,000 people, 28% had a mental health flag. So if you think about the overall population of about 200,000 people, right? We have about 9% with mental illness. And the population of people we see over and over and over again, based on this like one indicator of total bookings, 28% have a mental health flag. So they're the folks who kind of cycle in and out of the jail. They are 0.3%, infinitesimally tiny percentage, 649 people of all of the people booked. And they comprise 2% of your total jail bed days in the time period. If you kind of steps up one level. So people with psychiatric illness, or people who have a mental health flag, I should say. I don't have diagnoses, but a mental health flag indicative of potential psychiatric illness. There are 9% of the people booked. They took up 28% of the total jail bed days. So there's a little bit of a disproportionality in terms of use of resources that people with a mental health flag have. People who are a familiar face and have mental illness spent 40% fewer days in the community than even those who have identified a mental health flag who are not a familiar face. So the small group of people is spending a lot less time in the community, 172 days on average, than even people with mental illness who spend less time in the community than those without, as compared, like between one booking episode and the next. So this is like the kind of boring, difficult stuff if you're not into statistics that I did want to put out there for full disclosure, right? Because I said I had two goals. One, I wanted to identify indicators using county jail data that would tell me whether or not somebody has mental illness, potentially a screener, which is what the DCS flag is, right? It is 11 questions that make us think about, okay, this person might be somebody who has mental illness. I wanted to look in county jail data and see, can I use any data in the jail management system to help sheriffs identify these folks? And unfortunately, in part because of missing data issues and stuff like that, there was no there. I couldn't get there. So I couldn't get good predictive value, which is what these red percentages mean if you're going to do what's called a logistic regression. So if I take into account all of these different things, yes or no, can I predict which bucket you're going to fall into? Do you have mental health or not? The model only predicted about 11% correctly for urban jails. So not great, not huge confident, and 15% for suburban jails. So again, not huge confidence. So we're going to take another bite at the apple with a second phase to this study. Limitations, I said before, I'll say it again, right? The mental health flag in this study depends on a felony history. So if you have no felony history, I don't know. I don't know about you. I didn't have SIDS for about a third of the provided records. So we were not able to match about a third of the provided records, and then missing data on the cell movement for various jails made that indicator interesting, but not something that you could really use for prediction. We also had some missing data on release dates and that kind of stuff. So obviously no administrative data set is perfect. Our next steps, as of right now, we're working with 4 jails to compare the proxy indicators we identified in this initial analysis, things like cell movement, length of stay, number of days between booking episodes, and some others, and trying to come up with a validated screener using jail management system data, and then also using some of those screeners that jails collect with some heterogeneity. There's heterogeneity in the questions that jails ask at intake that might get us to potential mental illness and that they use to refer somebody for additional screening. But trying to just collect those questions and compare them to each other to assess the percentage with people with no felony history who screen positive for mental illness.
Stephanie.
Yeah.
Why did you limit this to, can you go back to the previous slide?
Yeah.
It says mental health flag depends on felony history.
Yes.
Why did you focus on felony history?
So those were the low hanging fruit, right? I have a certain amount of time and certain access to data sets. And the data sets that we had identified that we could join together to even get a sense of whether or not somebody had screened positive for mental illness were the felony data sets that we have available at the state level, which is DCS, GDC. If I wanted to try to get at more precise measurement, right? So either a diagnosis, which gets me into HIPAA land and that becomes a whole another ball of wax, or trying to get information on people from the jail medical provider, right? Like jail medical providers maintain electronic medical records and information about the people that they treat within the jail. separate and apart from the jail management system. And what we discovered when we did our initial round of interviews is that jail management systems are not necessarily capturing screener information in any kind of uniform way, or even all the time.
Okay.
So, no.
And so when you think in terms of data sharing, how would your study benefit from partnerships?
So, right. So one of the things that we are hoping to do, at least with the second phase, is get a little bit more data on the screener piece so that we can, do you want to move into the stemming the flow discussion? Because we can talk a little bit about.
You know what? Why don't we do that? We only have about 10 minutes left, and I apologize that we've run out of time. We've had a pretty thorough discussion on a number of topics, but this is going to be truncated, abbreviated. Sure. So let's go ahead and talk just a little bit about stemming the flow of people into the mental illness, stemming the flow of persons with mental illness into the criminal justice system. And just give us your top thoughts on that in the 10 minutes that we have remaining. We'll try to leave a couple of minutes open for questions.
Okay, so I'm going to try to speak quickly and put up my first disclaimer, right? Which is I know what I know and I know what I don't know. And I haven't had time to talk to DBHDD in any meaningful way about what potential data sharing looks like, what data sources are available to share, how do you even go about sharing, right? What I know is we did a study, we used felony data sets, we were able to answer some questions. We got a conservative estimate of the number of people in county jails who have mental illness. We've got some insight into repeated cycling and familiar faces and the impact that this population is potentially having on county jails. But what we don't know is the connection between this population that we observed in county jails and the mental health system, whether it's public or private, right? So some questions. What is the current level of connection between people who have criminal justice involvement and mental illness or co-occurring and mental health services, right? And y'all are kind of starting to ask those questions. How are you getting referrals into AOT? Are you getting people out of the jail? What's the connection between your law enforcement entity and a behavioral health crisis center, right? Is there a connection there? To what extent are folks involved in both systems? How many people have been restored to competency while they're in jail? One of the things anecdotally that we heard is it takes a lot longer for somebody with psychiatric illness in the jail to get out if they're on pretrial status, because if they are not competent to be arraigned and to, kind of attest to their charges and stuff, they've got to wait to be restored to competency. And then if they decompensate when they come back, lather, rinse, repeat, right? So that's an issue that we just don't know. We don't know what the overlap is. How many people are how are people accessing services and how are they paying for them? And then, somebody talked about the temporality. I think it was you, Judge Romero. You asked the question, and it's funny because you hadn't even seen the slide, but what comes first, right? Do people get into psychiatric crisis, they get involved in the criminal justice system, and eventually they make their way to services, or are they in services, they fail to service uptake, and then they end up in the criminal justice system? So trying to assess temporality and matching data sets together that would help you assess temporality is one of the things. If we're talking about, do we need to do data matching? How do you go about doing that? First thing I would say is you need a committee. And everybody loves to be part of a committee, and we're all part of several committees, including this one. But you need to have people talking to each other and working together and create buy-in to even start talking about sharing data and matching across data systems. So DBHDD is kind of key, obviously, to providing insight both into the complexity of the mental health systems, but also into the complexities of their own data and what they're already collecting on the people that they serve. The Georgia Sheriff's Association and Georgia Chiefs of Police, we have over 600 law enforcement entities in the state. We have 142 jails. Some of them have the same jail management system. Some of them have different jail management systems, and their level of access and ability to pull data out of those jail management systems varies widely. Department of Corrections, Department of Community Supervision, and Pardons and Parole, in some ways, those are low-hanging fruit from a state sharing perspective because they're state-level databases and their data rocks. That's all I can say. I've worked with it quite a bit. It's very good. And then obviously Department of Community Health looking at access to Medicaid and payment, use of Medicaid dollars to pay for mental health services. Like Monica talked about, not everybody is going to go to a CSB. Not everybody is going to go to basically like one of the providers that they have purview over, and maybe they're using Medicaid dollars to pay for a provider that's outside of DBHCD's network. We would never see that and have insight into that just using DBHCD data. So if I'm thinking of preliminarily like identified data sets and trying to match data across data sets, some data sets to consider: jail management systems. Again, there are, like, Eagle is a big provider, for instance, and we work with Eagle on 2 of the counties that are our partners, and they're fantastic. They're super easy to work with, and they have quite a number of jails in their portfolio. Another, Odyssey is huge, right? That's another kind of vendor working with jails. So if we got like Eagle and Odyssey and the sheriffs who use those to play with us, then maybe we'd get a good number of jails to have jail data. And then computerized criminal history with GBI gives you insight into arrest history beyond just what is in the jail management system, right? Because the jail only has insight into the people who are coming in through their turnstiles. They don't see necessarily everywhere else in the state. Go ahead, Judge Amaro.
What are the barriers to these groups of data sets sort of playing together, to use your terminology?
So a couple of things, right? Number one is privacy and being able to get around the legal frameworks to match, especially PHI, between criminal justice and the mental health system without a release. So if you're doing it either for research or operational purposes, maybe you can get around with an IRB. I've written it up before in terms of getting waivers and all this kind of stuff. If you're looking at retrospective data, not going forward. And then obviously, if you wanted to go forward, you would need like an ROI for ongoing release of information. And to be honest, I'm not like 100% certain whether or not an IRB would go for like, we're just going to match all these data sets together, de-identify them and study it. And everything is going to be okay.
Just tell us what we can do to help with that. Can you make some recommendations in that regard at some point?
Sure. So, right. So the challenges I've kind of been to access to data. I think the first piece of it is getting a group of folks together, because to understand our ability and whether or not we can share data, we need to sit down and have a conversation about what the rules around data sharing are, and whether or not from a research perspective, you can actually do this. And then if you can do this and folks are saying, yeah, we're willing to play, we can make this happen, then what are the mechanisms to make that happen, to protect the person and who's going to do the work, right? Protecting the patient health information. How are you going to make sure that the final data set is stripped of identifiers, so on and so forth. So it's lots of conversations. And then I would say 80% of this work is conversations, partnerships, and understanding the regulatory framework. 20% is actually swapping data and making, the widgets sing.
If you could just identify who needs to have those conversations at some point for us, then that would be helpful.
Sure. And I'll share this presentation, right? I think the last thing that I'll say, so complexities, things that would be really, really difficult to access. 911 data, there are 182 public safety answering points in the state, and a lot of those data are maintained in narrative. I've analyzed 911 data for one county. Oh, Jesus. Law enforcement agencies, 600 law enforcement agencies, each with their own records management system. I guess the other piece that I would say is a challenge, not to keep throwing challenges at you, Judge Amaro, but what we call entity resolution, right, in the data mashup business. Knowing that Joe Smith here is Joe Smith, there is Joe Smith, in DBHD is Joe Smith in the records management system of a law enforcement agency, right? And so having enough identifiers to make those matches can be sticky and tricky. Court cases are even harder because I don't even know how court data are kept and what identifiers are available in court data. I mean, I've had some insight into court data systems, but not a whole lot to speak intelligently to it. And then obviously non-DBHD funded treatment providers, we might get to some of that with Medicaid, but not everybody. Same thing with like homelessness services and that kind of stuff. Emergency room hospital data. I know DPH has OASIS and they publish like reports and they collect those, I think, in a de-identified manner. I don't know that a statewide system exists. Yeah.
I'm sorry, go ahead, please.
And then, kind of thinking through like potential deliverables, what does something like this look like, right? understanding the magnitude of the interaction. In this Venn diagram, how many people are here? How many people are here? Understanding kind of from a business process perspective, where are the cracks? Where do people fall? And kind of the back and forth between the two systems. And then lastly, right, if we wanted to do ongoing data sharing and build a repository or have a way for the criminal justice system and the mental health systems to interact on an ongoing basis, you're looking at business process analysis, technology, implementation costs, and kind of the regulatory framework. You still have to come up with that, right, for ongoing data sharing between the two systems. So.
And there's our discussion points. Let me see.
Yeah, so folks I said to who needed to be in the committee to start: DBHCD, law enforcement, the state law enforcement agencies, and DCH. Just if you wanted to start to kind of chip away at what these overlaps are.
Boy, oh boy.
It needs to be at the table, right? I don't know. I know some of the things, but not all of the things. That's just like first, like, these are the questions.
Judge Amero, can I say one thing?
Please.
I'm chair of the co-chair of the Judicial Council Committee on Technology. And there's a subcommittee, of course, there's Senate Bill 441, but their subcommittee, we've been working on data elements in the judicial system right now with TJ Dement. And so we've kind of got a little head start. I would love to discuss with you if I'll send you my office number or whatever. If you get a chance we could discuss. I may even have a presentation sometime to the technology committee, because everybody has to, I'm all about data. Of course, we have the work, with Judicial Council, they have the workflow committee, and so how we decide how many judges we get, which determines DAs and public defenders, and so it's all about data, and we all work in these silos. And we've got to find a way to break that and have some bridges. The technology exists. It really basically comes down to money. I mean, Fulton County has had the Socrata system for years. Before it was bought from they owned it before Tyler. And I'm sure it's millions of dollars if you're going to do something this scale. But they're not the only player out there either. And so I mean, there's. I think it becomes a political question. What agencies would participate, budget wise, but we've got to start looking at some of those higher level questions, because it's all about data.
Well, you can't make good policy without it. And
right.
And Stephanie, first of all, I want to apologize to you for not giving you sufficient time for this complex first presentation. There's so much that we could do with a little bit more time, but I think that these discussion questions that you put here on this last slide are extremely important. Maybe the members of the committee and anyone who's watching could provide you with some feedback to your email address, if that's okay. Sure. I think this is one of those presentations that you have to sit with and wade through. And kind of ruminate over, and then provide some feedback. I think our discussion might be better with you at some point, maybe in 5-6 months after you've had a chance to think through this. But I'd like you to answer these questions in a way that you think they would best be answered. What kind of deliverables can we reasonably expect in the next 2 years? What kind of who do you know through all of your 12 years, I think it is, working for CJCC, who you think would need to be a part of this conversation and answering some of these questions? And maybe you could suggest committee members to answer the question, are these key questions on the mark? I think you need a subset of folks who really deeply understand what you do and how you do it, and how the answers can sort of get us to a point where we, the criminal system and the behavioral health system are working together and understand each other going forward. So I know that that's not very helpful, but I just love what you're doing and how you do it. It's just so impressive. I really appreciate you being here. I hope you'll come back and talk to us again, even though we don't have time for a robust discussion.
Stephanie, this was awesome. Thank you so much. I really enjoyed this.
Absolutely happy to be of service. And yeah, I would think, number one, I have some expertise. I call myself a jack of all trades, master of none, in the criminal justice system. And I have lived experience as a family member of someone with mental illness, but then also have been looking at this issue for quite a while. And I think that even in the go forward conversations to refine some of these issues, right? Like DBHDD needs to be hand in glove working with us, because I have no level of depth in what they do and how they do it. And so I think I'm happy to do whatever you need me to do. And I ask my friends to help me, because I always do.
We've been saying forever that it's the same people. The people that they're seeing and the people that we're seeing are the same people. We just don't know how they interact with the two systems. And you just need to answer that question for us. If we could have an answer by tomorrow at 5, that'd be great. I know it's a Saturday. And does anybody else from the committee have any questions? I know it's just after 4 o'clock. I want us to get on with the rest of our day and our weekends. It's a beautiful summer day, and I don't want to keep you. So
I just wanted to say, I applaud Stephanie. This was awesome. I mean, trying to get hold of the percentage of mentally ill in the jail. That is something I worked for DBHD 30 years. We could never get that number. So I'm really glad that you're doing some work on that. I'm really interested, and maybe we can talk offline about how you define what a mental health flag is, because we do hear numbers all over the board or how many mentally ill are in the jail. So a lot has to do with how we define the mentally ill. And so I'm really interested in that. And the jails having different databases and, who's truly mentally ill or they're just depressed being in the jail. So I'm thrilled about what you said.
Dr. Bailey is going to handle the subcommittee on this topic, because she understands it better than the rest of us, I think, especially more than Steve. Holy smokes.
No, this interests me. Data and the jail data is it's something we could never get hold of because of the disparate data system. So yeah.
It's really great. Thank you again, Stephanie. And if there's nothing else that's really pressing, we'll just say sayonara and good night. And again, thanks to the department for being with us. If there's ever anything that you need that we can assist you with in terms of, I hope that you'll please reach out. Have a great time this weekend.
Thanks for the invite.